You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology. And this is This Week in Cardiology for March 2nd, 2018. This week, another study comparing diets, a warning for the antibiotic clarithromycin, a new cardiac stent, the best choice for IV fluids, and hope for type 1 diabetes. Let's start with a diet comparison. Last week, we discussed a low-fat versus low-carb diet. The JAMA published study came out about equal. Both groups lost equal amounts of weight. This week, there is another study, this one from Italian researchers publishing in the journal Circulation. Their comparison is vegetarian versus a Mediterranean diet. They had about 118 participants, 78% of them women from the Florence area, and they had BMIs greater than 25 and abnormal lipid profiles. This was a randomized open crossover study with 2 3-month intervention periods. Researchers found that both groups lost about 1.7 to 1.8 kilograms, which wasn't statistically significant between the groups. During the vegetarian diet, about 44% modified their cardiovascular risk category and reached the ESC recommended target levels. During the Mediterranean diet, about 34% of participants modified their CV risk, with 7 reaching the target for total cholesterol and 6 for LDL, 8 for triglycerides, and 10 for BMI. The vegetarian diet is low in cholesterol, total fat, and saturated fatty acid, leading to lower rates of cholesterol in the bloodstream, whereas the Mediterranean diet can reduce triglyceride levels through its beneficial components, including olive oil and dietary fiber, and many phytonutrients, and this is what the authors wrote in the paper. They found no significant differences in the levels of oxidative stress markers or inflammatory cytokines after 3 months of each diet. The summary here is similar to last week. More and more, I don't think we're going to find big differences between diets that are all low in calories, low in processed food, and low in simple sugar. Next topic is a clarithromycin warning. This week, the FDA issued a drug safety communication on the use of the antibiotic clarithromycin in patients with heart disease. Now, specifically, it's a warning on an increased risk of death in patients with heart disease, and it advises clinicians to consider using other antibiotics. And the FDA cited a 10-year follow-up from the ClariCore trial, which was an RCT, randomized controlled trial, comparing clarithromycin 500 daily versus placebo in patients who had stable coronary disease, on the idea that the antibiotic active against chlamydophila pneumoniae would reduce clinical manifestations of CAD. But instead of finding benefit, this original trial showed harm. The antibiotic for 2 weeks compared with placebo in these patients with stable CAD increased the all-cause mortality by 27% at 2.6 years and by 20% at 6 years after randomization. The 10-year follow-up from this study showed an increase in all-cause mortality with a hazard ratio of 1.10 and an increased CV mortality with a hazard ratio of 1.19. Now, they did some detailed analysis and they found that the increase was driven by deaths outside the hospital in patients not on statins in the first few years. But during the last 4 years of the study, cardiovascular deaths outside the hospital was lower in the clarithromycin group. The authors think this reversal was due to frailty attrition bias. Now, neither the authors nor the FDA gave an obvious reason why there'd be an increased death signal from clarithromycin. I also don't understand why the warning came in 2018 while the 10-year follow-up study was published in 2015. Nonetheless, it looks like avoiding this antibiotic in patients with coronary artery disease is probably wise. Third topic, there's a new stent. FDA has approved the Resolute Onyx 2.0 millimeter drug-eluting stent, and this is the smallest drug-eluting stent available in the United States. Medtronic, the maker of the stent, said this was to fill an unmet need. I wasn't going to cover this story, but this week one of my interventional partners brought it up, saying he thought he would go his entire career and not ever use a 2.0 millimeter stent. And why, I asked him. He said, because the best thing to do for these small vessels is to step away. And he added that stepping away doesn't mean doing nothing. I mean, the way to treat diffuse coronary artery disease is to eat a good diet, exercise, take guideline-directed medical therapy, for instance, statin drugs. The other interesting thing that got me thinking about covering this story is that the interventionalists in my hospital, including the electrophysiologists, are far more conservative than the non-invasive doctors. It's just interesting that the people doing the procedures are less aggressive than the doctors referring for the procedures. I wonder if that's the same in your hospital. Next topic is normal saline versus lactated ringers. This debate dates back decades, and I remember it from medical school. Which is the best IV fluid resuscitation? Researchers from Vanderbilt have given us a pretty solid answer, and it looks like it's balanced crystalloid fluids that get the nod. These were two studies published in the New England Journal of Medicine. One study compared the two IV fluids in critically ill patients in the ICU, and the other study compared the IV fluids in non-critical patients admitted from the emergency department. The investigators used a cluster randomized multiple crossover design. In the study looking at critically ill patients, the so-called SMART study, the balanced crystalloid group had a 1.1% lower incidence of major adverse kidney events. That p-value reached 0.04, and a 0.8% absolute reduction in hospital mortality. That p-value was 0.06. In the study looking at non-critically ill patients, the so-called SALTED study, hospital-free days did not differ between groups, and the balanced crystalloid group resulted in a lower incidence of major adverse kidney events within 30 days compared with the saline group, and the absolute difference here was 0.9%, and that p-value was 0.01. The accompanying editorial took a very cautious tone, noting that these were single-center studies and entry into the study depended on the patient's location. It also noted that none of the currently used resuscitation fluids are physiological, and questions regarding their safety and efficacy will remain, and despite the results of these two trials and any other randomized controlled trials that are currently recruiting participants. I say, okay then, but seriously, these sort of pragmatic trials are exemplary, and we certainly need more of them. I say good on the Vanderbilt research teams for doing these important trials. Next topic, final topic, is the prevention of type 1 diabetes. Now, most experts believe autoimmune-mediated destruction of pancreatic beta cells causes type 1 diabetes. But to date, immune suppression therapies have not worked. A group of researchers from the University of Florida and University of Colorado may have made a breakthrough in prevention of type 1 diabetes. Prevention. I've never covered a story in the Journal of Clinical Investigation. I'm not a basic scientist, so I'll have to keep it pretty simple. This research group, focused on the DQ8 gene in the human leukocyte antigen, or HLA complex, because it is linked to autoreactive T-cell responses in the majority of cases of type 1 diabetes. Now, through a series of elegant animal studies and an exhaustive search of already approved drugs, the researchers discovered that methyl-dopa, an old blood pressure drug, inhibited T-cell responsiveness and blocked antigen presentation by DQ8. Now, they first learned this in mice and then studied it in humans with recent onset type 1 diabetes. And get this, the drug resulted in a 40% reduction in DQ8 antigen presentation by mononuclear cells. 17 of the 20 patients they studied had a significant response, and that included glycemic control remained steady over 3 months, as well as endogenous insulin production also remained steady rather than declining. The group's next step is a phase 2 trial comparing methyl-dopa to placebo in children and adolescents at risk for type 1 diabetes who have the immune protein, and they're going to assess the safety, efficacy, and mode of action of methyl-dopa in preventing antigen presentation. Now, this is very early work, but I chose it for the podcast because the science is so cool and because it might have a great clinical impact on a tough disease. Before I close, I just want to note that next weekend is the 2018 ACC meeting in Orlando, Florida. I'll have a preview column up next week. I also recorded a ACC preview with Dr. James Rudd, who is the digital editor of the British medical journal Heart, and that'll likely be up next week as well. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.